EP48, the truth about statins, what seniors need to know. Statins are among the most prescribed medications in the world and among the most debated. Millions of older adults take them daily. Many take them without fully understanding what they do, what the evidence says, what the genuine side effects are, and when they are and are not likely to provide meaningful benefit. This is not anti-medicine content. Statins are genuinely life-saving medications in the right patients, with an exceptional safety record. But they are also sometimes prescribed in contexts where the evidence for benefit is weak, and patients deserve to understand the full picture. Today, we're covering what statins do, what the evidence actually shows about their benefits and risks, and the informed questions you should be asking your doctor. Statins, a class of drugs including atorvastatin, rosuvastatin, simvastatin, and others, work by inhibiting HMG-CoA reductase, the liver enzyme responsible for cholesterol synthesis. This reduces the liver's production of LDL cholesterol, the so-called bad cholesterol, and also modestly increases HDL. But statins do more than lower LDL. They have pleiotropic effects, meaning effects beyond their primary mechanism, including reducing inflammation in arterial walls, stabilizing atherosclerotic plaques, and improving endothelial function. These effects may account for some of their cardiovascular benefit independent of LDL reduction. The key question is not whether statins lower cholesterol, they reliably do, but whether that translates into meaningful reduction in heart attacks, strokes, and death, and for whom. The evidence for statins is most robust in one specific context: secondary prevention, people who have already had a heart attack or stroke, or who have established cardiovascular disease. In this group, statin therapy consistently reduces the relative risk of a second heart attack or stroke by approximately 25 to 35%, and total cardiovascular mortality significantly. The absolute benefit is meaningful. For someone who has already had a heart attack, a statin prevents a significant number of future events per 100 treated over 5 years. For high-risk primary prevention, people who have not had a cardiovascular event but have multiple major risk factors such as diabetes, hypertension, smoking, strong family history, or high calculated cardiovascular risk. The evidence is also reasonably strong, with statins reducing event rates measurably. These are the contexts where statin use in older adults is well supported by evidence and generally recommended by cardiological guidelines worldwide. The picture becomes considerably more nuanced in LOW to moderate risk primary prevention, particularly in older adults who have not had a cardiovascular event and whose overall cardiovascular risk is moderate. In very elderly adults over 75 or 80 with no prior cardiovascular event, the evidence base is significantly weaker. Most of the major statin trials enrolled predominantly younger populations. Absolute risk reduction is smaller. The time horizon needed to benefit may extend beyond realistic life expectancy in frail elderly patients. Additionally, in the context of frailty, polypharmacy, and reduced life expectancy, the balance between benefit and burden of medication shifts. For a frail 85-year-old taking 12 medications, adding a statin for marginal absolute risk reduction may not be the best decision. This does not mean statins should not be used in older adults. They should, when clearly indicated. It means the individual calculation of benefit vs. burden matters, and the conversation with a doctor should be genuinely individualized. Statins are among the best tolerated medications in widespread use. Serious side effects are uncommon, but some side effects are worth knowing. Muscle pain and weakness, myalgia, is the most common complaint, reported by 5 to 10% of statin users in practice, though in blinded clinical trials, the rate attributable to the drug versus placebo is lower. The rare but serious complication is rhabdomyolysis, severe muscle breakdown, which occurs in fewer than 1 in 10,000 users. Risk is highest with higher doses and with certain drug combinations. Elevated liver enzymes occur in a small percentage of users and are usually reversible on stopping the drug. Routine liver monitoring is no longer universally recommended as serious liver damage is extremely rare. Increased diabetes risk. Statins modestly increase the risk of new-onset type 2 diabetes, approximately 1 additional case per 100 to 200 treated patients over 5 years. This risk is higher with high-dose statins and in those already at risk of diabetes. Cognitive concerns. There are anecdotal reports of cognitive side effects, memory issues, confusion, but large observational studies and clinical trials have not established a causal link, and some evidence actually suggests statins reduce dementia risk. If you are currently taking a statin or being offered one, these are the questions worth asking your doctor. What is my actual 10-year cardiovascular risk? This number should inform the decision, not just the cholesterol level in isolation. Have I already had a cardiovascular event? This significantly changes the benefit calculation. What is the absolute risk reduction for someone with my profile? Ask for the number of people who need to be treated to prevent one event, not just the relative risk reduction. What side effects should I watch for? Given my age, other conditions, and other medications, does the evidence support this being beneficial for me? Can lifestyle changes, diet, exercise, weight, meaningfully change my cardiovascular risk? These questions are not adversarial. They are the questions an informed patient should ask, and a good doctor should welcome. Statins are genuinely valuable medications that save lives in the right patients. They are also sometimes prescribed without a fully individualized assessment of whether the specific patient will benefit more than they are burdened. Knowledge is not the enemy of treatment. It is the foundation of good treatment. Understanding the evidence and having the informed conversation with your doctor leads to better decisions for you specifically. See you in the next video.